Okay.
Good morning, everybody. I know you've been watching us chat for the past couple minutes, but we appreciate you being here, and now we're ready to get started. I'm Katie Earle. I oversee the University Express program for the Erie County Department of Senior Services, and we're back again with Sue Stoklosa. Thank you, Sue. She's amazing.
Oh, come on.
I made it. We appreciate you. So before we get to Sue's presentation, our usual housekeeping things, we are recording this session and I'll try to post it on our website in the near future if all goes as planned. You're muted. You can't do anything about that. It's not because you've done anything wrong. It's just our settings for today. So we'll be using our chat feature. If you're new to us, your chat is located on the lower right-hand side of your screen if you're on a computer. And if you're on a tablet or smartphone, you'll touch your screen. That'll bring up your control panel, and then you'll click that button with 3 dots, and there you'll see your chat. So feel free to type any questions or comments or topics that you want to learn about as Sue is going through this presentation, and she'll pop or pause every now and then to see if anything came through, and that's how we'll go with that. Quick shout out to Senior Services and how wonderful we are, or we think we are anyways. We do a lot of great things. We have our classes, but we have volunteer opportunities, case management, transportation. We can help you enroll with benefits and see if you're eligible for things. So if you're looking for help or you know of somebody who's looking for help, please give us a call and we'll do whatever we can to get you where you need to go. So the star of our show, Sue is a nurse practitioner with about 14 years experience in pulmonary and critical care practice. In this practice, she managed and educated obstructive sleep apnea patients. She recently lectured on OSA at the New York State Nurse Practitioner Conference. She currently teaches the next generation of nurse practitioners at Damon College, and she is also a certified basic life support and advanced life support instructor and has been with University Express for a couple years now. Sue, thank you so much. I'll turn it over to you.
Okay, thank you. Good morning, everyone. So, we're going to talk about one of my favorite organs after probably lungs is the kidneys. Um, and these remarkable little organs, what they do and how we can protect them and what of each of our roles are in them. So, we'll start off just with a little bit of anatomy. Sorry, I'm going forward too much. Let's go back. So the kidneys, we have 2 of them. They are on either side of our flank, kind of sitting right below the diaphragm. They're protected a bit by the rib cage comes down and the kidneys are a little bit under there because they are, important organs and we don't want to damage them. They are, they filter all of our blood many, many, many times an hour. And this is the basic anatomy. And just what I wanted to show you is that, so right off the big main blood vessel that comes off our heart, the aorta, is where the kidneys arteries come off, or we call them the renal arteries, because we need to the body needs to filter all that blood. So you see the renal artery, the renal veins. Arteries take blood away from the heart. Veins take it to the heart. So the artery is coming from the vein. It goes into all these little crevices. And in another picture I'll show you, these are loaded with blood vessels because all the blood needs to be filtered through there. And they're also loaded with things called nephrons. And they're, so it goes through here. And then this big one, this big white, that is part of what they call the renal pelvis. That's where the urine collects. And then here's the ureter. That's where the urine goes down and gets collected in the bladder. So here's another picture that shows just a little bit more of the blood vessels and all of the blood vessels into the renal column. You don't need to know this, and it's just how impressive these organs are. Bigger, the blood vessels get smaller and smaller as they go deeper into the kidney. The medulla is where the workhorse, where the factory of the kidney works. And then again, the pelvis, and then down to the ureter. So this is the workhorse. This is called the nephron. And it's, again, it's very complicated, complicated for me, but what I want you to take away from this is just how spectacular are these organs. These little nephrons, there's millions of them in each kidney. The creator gave us a very redundant system here. So if a bunch of these go down, our kidneys are still working. So just to point out a couple things that you're going to hear, you see in your lab work. So these little things here, the glomerulus, and that is kind of, again, the workhorse of the kidney. And that's where we get, when you get your lab work, the GFR, or the glomerular filtration rate, how fast or how slow this area is filtering your blood. So through here, it does, just crazy things. It looks at the electrolytes. Do you need more sodium, more salt? Do you need more potassium? Do you need more fluid? The kidneys are very sensitive to blood pressure. So if the blood pressure goes down, it perceives you need more fluid. It'll keep more fluid. It'll keep more salt. If the blood pressure goes up, it will do the opposite. Get rid of salt, get rid of fluid. So it's constantly readjusting for the electrolytes, for the proteins, for the fluids. And after it gets done, it still has more to do going through all these tubules. This is the last one it goes through, this loop of Henle, where it's the last time that the kidneys kind of work on, do I need to keep more water? Do I need to send more water out? And then eventually we'll go through what this is, the collecting system, and start to pool as
Whoop. Sue, did we lose you?
but it can sneak up on you too, I guess. So how does the kidneys make urine? So we talked a little bit about the glomerular filtration. So all the blood gets filtered into that little capsule there, and that decides different enzymes and hormones, and different pressures, like fluid pressure, what they call osmotic pressure. They decide how much fluid, how many of the electrolytes, that's the sodium, the potassium, the chloride, phosphorus, magnesium, all those electrolytes that our cells need to function. The kidneys decide how much to keep, how much to get rid of in the urine. And then one of the big jobs too is protein, which we're going to talk a bit about, because that really tends to be the first problem we get when the kidneys start to have problems. And what I mean by protein removal is our blood, our plasma is full of proteins that are big. Well, they're not that big, but compared to the other molecules in our blood, they're large. And the kidneys have to work at keeping that regulated to also help with fluid and having protein in our bodies. So when they talk about tubular reabsorption, that's the fancy word for the water gets reabsorbed in those tubules that we saw. We'll go back one. So that's through these tubes. The body perceives, the kidneys perceive they need to reabsorb, take more water in. You're a little bit dehydrated. We need to take more water in. Tubular secretion, opposite. You have a lot fluid you don't need. We can pull that fluid out and secrete it out into the urine. And depending how much water and proteins are in the urine will give us what they call specific gravity, which is the concentration of the urine. So, sometimes like when you go to the bathroom, sometimes your urine is really pale yellow, and sometimes it's really dark, especially in the morning. That's the kidneys working to either concentrate. So if the urine is dark, it's concentrating. It doesn't have as much water in it. If the urine is real pale, it's getting rid of more water. So maybe for some of you who are on water pills or what they call diuretics, after you take them, your urine looks very clear because you're getting rid of a lot of water. So the proteins that we kind of alluded to. So if you've had your blood work drawn, and there's this picture here. So this is a, when they draw your blood, eventually it'll separate out into plasma and blood. So this is the blood components, the red blood cells, hemoglobin, white blood cells. This is the proteins that are also mixed into the blood. And they play a very important role besides everything that our body builds needs protein. It plays a very important role in fluid again, because the proteins keep the fluid in the blood vessels. If your proteins are low, the fluid seeps out of the blood vessels and it goes into your ankles. And you get things like edema. So about 55% of your blood is plasma, and about 7% of that is proteins. And the kidneys have a big job with the proteins. Now, going back to the proteins a second, one of the issues with the proteins are they're bigger molecules. They're tougher on the kidneys to reabsorb, through those tubules and through that little glomerular capsule. So when those nephrons start to have trouble, usually the first trouble they have is getting the protein back into the blood system, reabsorbing it. And then you start to spill protein in your urine. So that's why we're spending time on the protein. Any questions with that? I know that's a lot of physiology there.
Nothing came through,
Okay.
Sue. You're
Okay.
explaining it very well. Thank you.
Thanks. So just to go over again a little what the kidney function is, when we talk homeostasis, that's our fancy word for stability within the body. And almost every major body function, or the big ones, the kidneys are part of the process to maintain stability. Your blood pressure being one of the bigger ones. You don't want it too low, you don't want it too high. The fluid balance, your electrolytes. If your potassium is too high, you can have a lot of heart issues, or too low, same thing. So it really works on the overall homeostasis or stability of the chemical functions and the fluid functions in your body. Again, electrolyte and fluid balance, constantly monitoring that and shifting. When we have metabolism, or the cells have to have food and energy, and they have energy so we can talk and heart can beat and all those things. So one of the byproducts of that is a nitrogen waste, in particular ammonia. The kidneys get rid of that too. They will filter this nitrogen waste out, and it'll show up in the urine. The kidneys are very important in what we call acid-base balance. So the body, you have an acid, or you have a base on the other side, which is more like alkali. The body functions well at a very narrow range. It functions, these numbers aren't really important, but just to tell you give you the range. It functions well between a pH, an acid-base balance, 7.35 to 7.45. Too high, certain things don't work, like getting oxygen off the hemoglobin. Too low, a lot of things don't work. And the kidneys are constantly, again, monitoring the acid base. And their part of it is if it gets too high or too low, the kidneys can change the bicarbonate. We all know bicarbonate of soda, that's a base, right? Bicarbonate levels to modify this. Now, the renin-angiotensin system, and mention this because it's important, but also a lot of our blood pressure medications now that also help the kidneys work on this system. So this is the system within the kidneys. They're enzymes that monitor the blood pressure and how much blood the heart's putting out. So if the heart is not putting out as much blood or the blood pressure is low, the kidneys will excrete this enzyme, this angiotensin. And what that does is it tightens things up, the blood vessels up, keeps water in too, so we get the blood pressure up. Again, when we were designed to have these protective mechanisms, but the protective mechanism against low blood pressure is like getting, bitten by, a saber-toothed tiger. It's always that you have blood loss or those kind of things. So the body's always going to try to, when it sees a low blood pressure and the heart not working as well, will try to tighten everything up and keep fluid in, thinking that you're hemorrhaging. That isn't always the case. The other thing it does is it also has this enzyme, yes it is, erythropoietin, which helps make red blood cells. So when the kidneys perceive that the red blood cells, which in the blood, which carry the hemoglobin, which carry the oxygen, are low, it will excrete erythropoietin, which will go to the bone marrow and make more red blood cells. It helps in the metabolizing insulin and also in metabolizing vitamin D. So you see there's a lot of things that it has its fingers in, let's say. So just a little bit about regulating blood pressure, though we talked a bit about it. We talked about that plasma pressure, the proteins that keep the fluid in the blood vessels, the fluid balance, a little more fluid, a little less fluid, maintain that blood pressure where we want it. The renin system, again, how the body can respond with the help of the kidneys for a low blood pressure is called vasoconstriction, which is the fancy word for the blood vessels tighten up. So if the blood vessels tighten up, what happens to the blood pressure? Goes up, right? Because it's got to pump through bigger pressure. If it dilates, the blood vessels dilate, what happens to the blood pressure? It goes down because it doesn't have to, the heart and that doesn't have to pump or push against as much pressure. And then it also will keep fluid and sodium in this renin system because it will try to keep more fluid in the body. There's other hormones that it will excrete to raise the blood pressure. And there's also another hormone in the kidneys that's called antidiuretic hormone. Now, so a diuretic, if you're on a diuretic or a water pill, we know what happens, right? You get rid of fluid. You diurese, it's a water pill. So this hormone, antidiuretic, sends a message up to the brain and also, it works in the kidneys to not make as much urine. So you're not peeing as much. You're keeping more fluid in. So those are the mechanisms how the kidneys regulate the blood pressure. So let's talk, so there's kind of in a nutshell, what these remarkable little organs do for us day in and day out. And we don't even need to think about it, except maybe if we need to go to the bathroom. So anyway, so what are the numbers for chronic kidney disease? Now, the thing is about chronic kidney disease, so as I said, there's a lot of redundancy in the system, and it takes you have to lose a lot of quite a bit of kidney function to have symptoms sometimes. But as we get older, our kidney function decreases. We lose nephrons, our kidneys get tired. We don't all go to kidney failure for sure, but there is some lessening of kidney function the older we get, and then there's other things that will contribute. Kidney disease in this country is one of the leading causes of death. About 37 million US adults have it. Now, chronic kidney disease, and I'll show you some tables about what that means. Well, how's that diagnosed? But most of us are undiagnosed. 40% of the people with severe kidney reduction in kidney function are not aware of it. Of course, they're not on, so that's some work for my profession, my group to be doing. Every 24 hours, 360 people begin dialysis for kidney failure. In the US, by far, the two biggest causes of kidney disease and kidney failure are diabetes and hypertension, high blood pressure and diabetes that are not, certainly not well controlled. I gave you a site at the end, the CDC, they have a nice site about explaining kidney disease. So early chronic kidney disease, there's generally no signs or symptoms. There is specific blood and urine tests that should be checked for chronic kidney disease. It does tend to get worse over time as we get older. Our kidney function will just naturally decline. And then depending on, medications and different things also. It can be treated, and the earlier the treatment starts, the better. And the treatment in the beginning with really mild, chronic kidney disease really is what we do, what we do for ourselves, because it's a lot of management of our other chronic diseases and medications. And chronic kidney disease can progress to kidney failure. And kidney failure is when we start talking things like dialysis. So what is the definition of chronic kidney disease? You have to have a reduction in kidney function for at least 3 months. It's not just a one-time bump. Your doctor repeats your labs and it comes down. You were sick, you had the flu, you were throwing up a lot, you got a little dehydrated, you had a little bump in your kidney numbers. That's not it. It's 3 months, at least 3 months consistently. And then what happens is that we talked about those little capsule, glomerular capsules. They start to lose functioning. And then the surrounding ones, the surviving ones, try to get bigger to compensate. And like anything, like a balloon or anything you stretch out, eventually it gets too big and it doesn't function. So then those nephrons fail. And then you start to get this cycle of loss of function, the other nephrons trying to compensate by getting bigger and putting more blood flow through them till they can't do that anymore. They lose function, then it cycles down. Again, the good news is that you can lose greater than 50% of your kidney function before then. After that, you're kind of in trouble. One important thing to remember if you have chronic kidney disease is that most people with chronic kidney disease will die of heart disease, will not die of their kidney failure. There is a large correlation. You see how closely the heart and the kidneys work together between heart disease and the kidney disease. So especially in early stages, any stage, but you want to start thinking about controlling those risk factors for heart disease. Now, the reference I have here, this kidney disease improving global outcomes, that's like the drop down thing for us healthcare providers to go online, and they have guidelines for everything. But they also have a very nice patient education sites too. So that's another good website to look at. Just as a picture of how it can progress. It doesn't need to progress this way. but it can progress this way. So I wanted to show you a little bit, and I know this is kind of small to look at, but what you're getting or what we're looking at when your doctor, your healthcare provider orders lab work. And this particular one is what we call a CMP, or a complete metabolic profile. So you'll get some kidney function, you'll get the electrolytes, you'll get liver function. So we're going to focus on the kidneys. So if you come up here, this says urea nitrogen, or BUN. Now remember back, we talked about what is the waste product of metabolism, those nitrogen or ammonia. So the kidneys, that waste product, that nitrogen, will pee it out. So it's so that's what you're looking at when you're looking at a BUN. The creatinine, that is also a waste product of protein metabolism. And in both these numbers, higher isn't better, bigger isn't better, lower is better. So there's the ranges. So like for this particular patient, the creatinine is 1.14, which is still within normal, but high normal. And then the other thing, so they take these two numbers, this BUN and this creatinine, and they calculate, now it's all done in computer, the GFR, the glomerular filtration rate. And for these numbers, they give you a non-African American and an African American now. But the last, I went to a conference where this kidney person was talking, and I think they're going to do away with that. It isn't helpful, and it gives the African American GFR, they can higher, and they feel they're missing a lot of kidney disease. There's a lot of kidney disease in the Black population. So anyway, this person's GFR is 64. So remember that. So those are the kind of the three big things we look at as far as kidney function goes on what's called the complete metabolic profile. The glucose, yeah, 92, probably could be a little, it's okay. We're okay with that. Here's some urine studies. Again, we should be sending urine studies. So we look at proteins and other things. So you're going to get a whole bunch of stuff that's going to give you the color. It's going to say if there's glucose. Ketones are also a byproduct of protein metabolism. But here's the protein, and you want that to be negative. You don't want the kidneys to be spilling protein in the urine. And actually, this person with the leukoesterase positive and the microscope, that's a classic urinary tract infection. And they'll look at if there's white cells and things. But the proteins here is what we're looking at in the urine, that if you're spilling proteins. Also, if you're spilling glucose, because then your glucose isn't that controlled. One thing that they recommend sending are urine albumin results. So this is not total protein, but a part of that protein that we looked at in the plasma called albumin. And it's one of the earliest signs that the kidneys are having trouble when they're spilling albumin, this particular type of protein, into the blood, into the urine, sorry. And we'll look at how those tables look. But this person's urine albumin is 18. We start to, it starts to be abnormal when it's above 30. Okay, so how do we just decide the stages of chronic kidney disease? So the first category all has to do with the GFR, the glomerular filtration rate. So the person we just looked at had a GFR of 60. So comes right, or 64. So comes right in at stage 2. Kidney damage with mild decrease in GFR because it was 64, okay? Then if you had these albumin urine results, you would also look at that. because many times, you will see that start to rise a bit before you even see a GFR. And that also in combination, if they had a stage 2 chronic kidney disease, but we're also spilling albumin, that kind of bumps them up to a little closer surveillance. So if your doctor says to you, you have stage 3 kidney disease, this is what he's saying, that your GFR is mild to moderate. You're within that, 60 to 45 range. So again, the blood work we looked at, they were stage 2, and we didn't have albumin. This is another way that we look at it to see if it's called a heat map, but it's also looking at the prognosis or the risk that we see with our patients. So again, if we're looking at the GFR here, she was 64, mildly decreased. Let's say the albumin was the 18 that we saw. So less than 30. So they'd be right in this green zone. So they're low risk. Doesn't mean we don't watch them, but it's not, we don't have to step them up to another level. Let's say that they're mildly decreased at 64, but their albumin level, their albumin in their urine is 40. Well, that brings them up into, something that a moderate risk that we would have to watch closer. So this is how we look at those numbers. So what are the risk factors for chronic kidney disease? I've said them, sound like a broken record with this, but high blood pressure and diabetes are the two big ones by far and away especially in our culture, and not having them controlled well. Many autoimmune diseases will affect the kidneys. Lupus is one that comes to mind, but the immune system will attack the kidneys like it will attack the joints or anything else. Nephrotoxic drugs, fancy name for kidney toxic drugs, and we'll spend some time talking on that because that's a piece that we can help control, with our healthcare providers. And people who have other kidney diseases, someone who's had, was really sick at one point and had kidney failure, obviously they're going to be at a higher risk. There's other kidney diseases, kidney infections, things, but much rarer than the hypertension and the diabetes. Any questions with any of that or concerns? Or?
Nope.
Nope.
Not seen
Okay.
anything yet. Good.
All right. Everybody awake?
I think so.
Okay. So nephrotoxic drugs, very important. It's one of the things I, would star and one of my soapbox issues. Because let's say that you have stage 3 chronic kidney disease, which is not bad. It's moderate, and you're, probably not on any medication, probably not seeing a kidney specialist at this point. But things can tip over fairly suddenly sometimes if we're not aware of what we're doing or what we're putting into our body. And several over-the-counter drugs can be tough on the kidneys. The body has 2 ways to metabolize or to get rid of drugs, any kind of drugs, over-the-counter drugs, prescription drugs, drugs you're buying on the street, any of those, to get rid of them in the body. They either metabolize them through the liver or the kidneys. If they're metabolized through the liver, we don't have to worry about the kidneys. But if they're metabolized through the kidneys, then we have to see, what kind of adjustments need to make. One of the most common drugs that can cause kidney problems are the NSAIDs, are ibuprofen, Motrin, Advil. They're over the counter. They're great drugs, and I'm not saying that if you have stage 3 kidney disease, you can't take these. But you need to be careful, and you should talk to your doctor about what is the line here that I can take? And can I take Motrin? Um, Tylenol, which has its own set of issues, but it's metabolized in the liver. So you just need to be careful with these, what they call the NSAIDs. I like to say just because things are over the counter does not mean they're 100% safe. Anything, any drug you put in your body or herb can have side effects. And talking about herbal remedies, be very careful with those, where they're coming from. A few years ago, there was a rash of, true kidney failure from this Chinese herbal concoction. I forgot what it was called because they've taken it off. They won't let it come in the country anymore. But understand with a lot of the herbal things, and I'm not against those. I do some of those things too. But again, need to be careful. Um, the prescription medications, whether they come from China or from here, do have to be inspected and cleared by the FDA. That's why we hear of these medications from China being, they're being suspended because there was problems in the factories. The herbal stuff, the stuff that is not regulated by the FDA. So unless there's like with those Chinese herbal concoction, it's always something after the fact. They find these, this kidney disease, kidney failure going on. What's the common determinant? Well, they took this medication. And again, not saying that there's not some, blood herbal or alternative medications, but be aware that your body still has to metabolize them. Many of these things are not regulated or inspected by the FDA. I try to stick with things, with the stuff that I take, like I take turmeric. I try to stick with something that's made in the USA that I think at least has some, and there is a certifying body that's voluntary for these kind of medications. So you may want to look for that it's certified with this voluntary organization. They'll usually have a little ribbon thing on the back of them. And of course, the illicit drugs and the heroin, cocaine, ecstasy I shouldn't presume, but that can actually cause some serious kidney damage. So the take home here is you have to tell your provider of all medications that you're taking and any over-the-counter medications, any herbal medicines you're taking, protein drinks, anything, so they have a full picture of what your kidneys are, what your kidney function is, and how hard it has to work to metabolize these drugs. So you want everybody, and a lot of us go to several different kind of doctors. Hopefully they're all communicating, but you want to make sure that, at least your primary, or if you're seeing a kidney doctor, knows that, your cardiologist put you on this. So everybody's on the same page with the drugs because, there's antibiotics too that are really tough on the kidneys. Again, we can work around that if we know what's going on. The other thing to mention, because many of us are on water pills, on diuretics. The other thing that can kind of tip us over with the kidney disease is getting dehydrated. It really puts a big strain on the kidneys. The kidneys are very sensitive to low blood pressure and to dehydration, and you can kill off nephrons with low blood pressure. So again, the scenario, you get the flu, you're vomiting, you're not taking any fluid in, you take your water medicine anyway, you take your furosemide anyway. Now you're dehydrated. Now your kidney numbers all bump up, and sometimes that lands you in a hospital. So my advice with that is, if you do get sick and you're not able, not like for 12 hours or 24 hours, but if you are if you're losing a lot of fluid and you're not taking a lot of fluid back in, I would run that by your healthcare provider. Should I hold my water medicine? Should I still take it? Because there's other things you're taking your water medicine for, your diuretic for, besides fluid. But you don't want to get behind the 8 ball and get dehydrated when you get sick. Also, this time of year is very important too, as far as keeping yourself well hydrated within the limits of what your doctor or your kidney doctor has told you you can drink a day. But it's hot, you're losing what they call insensible loss through sweating, you're maybe not drinking as much. And we do know the older that we get, the less sensitive, like some of our thirst drives and things are, or our thermostats are. So it's a little bit easier to get, again, behind the 8 ball and being dehydrated. So, watch it with the warm weather too. Okay, moving on. So what are the kind of things we really try to strive for with chronic kidney disease? Early monitoring. And obviously I showed you those numbers earlier. We're not doing a heck of a good job there. But so early monitoring, what that means is lab work. We're not doing any kidney x-rays or anything like that. We just need to watch the labs, the blood work and the urine. Early intervention, which again, if we're starting to see some kidney loss, that we're, acknowledging it and taking care of it at the stage that it's at. And then the early intervention certainly includes tight control of modifiable risk factors. And what are modifiable risk factors? There are risk factors that we can change. So we might not be able to change that we have high blood pressure, but we can change that we can control it where we're supposed to. We may not be able to control that we have diabetes at this point, though we can, the blood pressure and the diabetes, and I speak, I'm constantly struggling too, we can control that as modifiable before we get it. If we, do, we all know what we need to do. But tight control, good control on our blood sugars, weight loss, good diet, heart healthy diet, no smoking, and watch the medications. Those are all things that we can do ourselves and modify those risk factors. So general management of chronic kidney disease. So basically, whatever stage you're at, this is kind of generally what we should be looking for as far as management, self-management, and the management that you're getting from your healthcare provider. Again, broken record, aggressively treat reversible causes or modifiable causes. So, again, blood pressure, diabetes, careful use of medication. Again, not saying you can never take a Motrin again if you have some chronic kidney disease. You just need to be careful. And it may be, depending on the stage of your kidney disease, you want to get some guidance from your doctor about how often you can take that. Controlling your glucoses, so controlling your blood sugars, optimal control of your blood pressure, smoking cessation, weight management, diet, and then optimal cholesterol management, including statins. Because remember I said, most people with chronic kidney disease will, when they do pass away, will pass away from heart disease, not from their kidney disease. So we need to keep an eye on those things that would keep us heart healthy. So I keep saying optimal blood pressure control. What is that? Well, the guidelines, those KINCO guidelines, I referenced, say that if you have chronic kidney disease, your blood pressure target should be less than 120 systolic. Now, this is a target. Your doctor knows too. I mean, some of us, again, especially as we get older and our blood vessels get a little bit stiffer, we may need a little bit higher blood pressure to get it all the way up to the top of our head, and to feel right. But that's the target, is about 120 systolic. If you have a transplant, generally if you have kidney transplant, they want your blood pressure a little bit higher, 130/80. What is the target if you have diabetes for your hemoglobin A1C? Less than 7. And the guidelines say that you should have a hemoglobin A1C 2 to 4 times a year, depending on if your hemoglobin A1C has been the same number for 2 years, twice a year. If you're changing medications and what have you, then you need to do it more often. You cannot do you probably know this, but you can't do a hemoglobin A1C too early. What they're looking at is it's hemoglobin, and it's the A1C, which is the glucose part, that's bound to the hemoglobin. Well, our body turns over red blood cells about every 4 months. So you have to repeat it after the turnover of the blood cells. So if you get a hemoglobin A1C 2 weeks after the doctor made some change on your blood sugar medicine, it's not helpful. It has to be at least 3 to 4 months afterwards, after those hemoglobin molecules turn over, because our body gets rid of them and they make new ones, and it's constantly in a cycle. So what are some of the health consequences of chronic kidney disease over and above, obviously, your kidneys aren't working? One of the problems that people, and again, we're usually talking at least stage 3B, stage 4 and higher, anemia or low blood counts. Again, going back to our, walk down the pathophysiology lane, the kidneys make that erythropoietin, which stimulates the bone marrow to make blood cells. So if the kidneys are having trouble doing their job, you're not getting enough, as much of that erythropoietin, and then you become anemic, which further complicates the kidney function and makes you feel lousy. Increased occurrence of infections. Generally, anyone who has a chronic disease is more susceptible to infections. Your electrolytes can get all messed up. You can have low calcium levels, high potassium levels, high phosphorus levels, because the kidneys are not filtering the potassium and the phosphorus out. The kind of crazy thing is as the phosphorus goes up, the calcium goes down. And they're inverse. So they keep an eye on that. You may have loss of appetite and eating less. The other thing that goes along with this, like a lot of chronic diseases, is depression and lower quality of life. You may not feel good. You have a lot of fatigue. You're worried you're gonna, end up on dialysis, and that's not it's not something to hide or not to talk to your doctor or your kidney doctor about, because we know that with any chronic disease, the more depressed you are, the worse the outcome is. So that's something just as important as treating your heart disease is treating the depression. Diet recommendations. It used to be anybody with any kind of kidney issue needed to go on a low protein diet. And you can kind of see why we thought that, because the kidneys are having trouble filtering proteins. Well, they've changed the recommendations. So there's no low protein diet in stage 1 or 2. In fact, we want you to eat a healthy diet. We don't, the lower your protein, again, as we kind of get older, the proteins build muscle mass. And one of the worst things to do as we get older is to lose muscle mass. So you don't want to really restrict the proteins until you have to. Stage 4 or 5, a lot of times you do have to do a low protein diet. And that will come from, generally at that point, you're going to be with a kidney doctor. Now, if you're on dialysis, they still restrict the protein, but you have a little higher level you can have, because being on dialysis also burns up muscle mass. So they found if you had a little higher proteins and a little higher muscle mass, you did better on dialysis. pretty much anybody with heart disease, high blood pressure, kidney problems should be sticking to or trying to stick to less than 2 gram a day sodium. Low or no potassium, only if your potassium levels are elevated. So they'll be watching that. So if your potassium is elevated, they'll talk to you about that. Fluid restriction, again, only with recommendations. The fluids are a difficult, again, you don't want to be dehydrated. You don't want to be overhydrated. As the kidney function gets worse, then generally, like we're talking again, stage 4, stage 5, generally you have to restrict some fluids. You can't drink a liter of pop because the kidneys are not going to be able to pee it all out. But that will come from how much you should come from your healthcare recommendations. Some people can drink 2 liters a day, some people 1 liter. It's all over the place. But generally, if you are not told by your doctor, kidney doctor, cardiologist to restrict fluids, do you drink a normal amount when you're thirsty? Probably the most important thing for most of us that aren't into, stage 4 or 5 kidney disease is a heart healthy diet that will be healthy for your kidneys also. So low sodium, watching the cholesterol, more of a Mediterranean kind of diet. Questions about diet?
Just a comment about thank you for bringing up the importance of drinking water. I am always trying to have my husband drink more, but not too much.
Right. Yeah. And generally, there's medications that mess with it. But generally our bodies are very good at telling us when we need to drink more. That's the whole thirst mechanism. So you usually can't get into too much trouble listening to what your body's telling you to do. Again, at the extremities of age, then sometimes that mechanism doesn't work as well. But if you're thirsty, drink water. And water is the best thing to drink. So lipid management. So the fat management, going on again about the heart issues. Your lipid profile should be checked at least yearly. The recommendations from the KINCO, from the Kidney Foundation, is if you're over 50 and your GFR is less than 60, so you're stage 3 kidney disease, you probably should start a statin if possible, of course, under the recommendation of your doctor, because we know that you are now at a higher risk. Your kidneys are struggling a bit. You're of that age. And the studies far and away show that if you are at a high risk and you start a statin, your risk of having heart attack and that goes down substantially. People do have side effects from statins, but quite frankly, it's one of the most prescribed drugs in the country. So the risk profile is generally quite low. Side effect risk profile compared to the studies coming out about heart disease. Now, if you're younger, if you're 18 to 49, they recommend treating with a statin if you have something else going on. You already have heart disease, you have diabetes. Diabetes is a big risk factor for heart disease. So they may want to think about a statin earlier. Triglycerides, those are really tied to how much carbohydrates you take in. So generally, if you decrease your carbs, the triglycerides will come down. I don't know if you were at my heart failure lecture, but this, and we should be able to light it up. This is the cardiovascular disease risk estimator. And a lot of your, docs and that now have this like right on their computer, right on their little laptop when they're putting your stuff in, and they'll give you a risk. So if you go to this website, it's going to work today. And there's all the stuff that you put in. And it's going to give you what your 10-year risk is. And that is how that is how we are to determine whether to start a statin drug, a Lipitor, based on your risk. We used to do, like, if you had X number, if your bad cholesterol was greater than 150, you got a statin. It's probably high, 120, you got a statin. Now they, because not everybody has the same risk. So they do this risk calculation and can tell you that. So I'll just put some. So say I'm 62, I'll make up a couple numbers. Female, white. My last blood pressure, I was very happy, 122 over 88. Total cholesterol was 140. HDL 70. My LDL is 70. No diabetes. Quit smoking about 30 years ago. I'm on blood pressure medicine. I'm on a statin, not on aspirin. So my current risk is 2.9, right? So if I did this, took myself off the statin, took myself off that, took this down to say 40, and this up to 100. That's my bad cholesterol. Oh, it didn't change it, but it should change it and go up. But anyway, at a risk of that, that's my 10-year risk for having a heart issue, having a heart attack, basically. So you can do that on your own, see what your risk is, but that's how we kind of figure out with the statins and risk modification. So important if you have kidney disease, take home message, is that you make sure that you are also watching your heart. Just going to look at this a second again because we're going to talk about, so that was general management. Anybody who has, some kidney issues, that's how you should be managing yourself, and we should be helping you manage yourself. So now we'll look into the stages. So I just wanted to pull this up again. Again, 4 or 5 is severe. 3, we need to be watching stuff. 1 and 2, we still need to watch it, but probably not making a lot of different changes except watching the medication and the heart problems. So stage 1 and 2. So that's a GFR greater than 60. Vast majority are everybody actually is managed by primary care. And we're going to manage those risk factors. Try to keep your blood pressure 120 over 80, or what your doctor wants you to have. Self-management education, like you guys are doing right now. Realizing you have an increased risk for cardiovascular events and managing those risks and treating the high cholesterol. So no smoking, a little exercise, heart healthy diet. Try to increase your physical activity. If you smoke, please stop. At least annually, you should have lab work done. You should have urine studies done, an albumin creatinine ratio, those numbers that we looked at on the chart. Lipid profile annually. Still be careful with the medications, low sodium diet, and weight management. So a lot of this is almost, you got a little bit of an issue, let's do some preventative work here. Stage 3, most of the time is managed by your primary care, depending on some other things like how much protein you're spilling or how fast your kidney numbers change. He or she may want to refer you over to a kidney specialist. Again, you should be monitoring your urine proteins, urinalysis, the creatinine, that level that we see in your blood. If you have, any of us, hemoglobin A1C managed below 7. Anemia workup. If you have low blood counts, you need to have an anemia workup. And then the general guideline is if you have stage 3 kidney disease with anemia, you're probably going to go see the nephrologist. There's medications for the anemia, like a medication called Procrid that stimulates which is actually that hormone which stimulates the bone marrow. So things that the kidney guy can do. Again, cardiovascular management and try to maintain that blood pressure either at target or what your healthcare professional says. Now, stage 4 to 5, that's generally a referral to the nephrologist or kidney specialist. You're still going to do the same, either keep that hemoglobin A1C less than 7. Try to keep that blood pressure 120 over 80, or again, what they recommend. I don't know if I said it in stage 3 because you haven't heard it enough already, but avoid those kidney toxic drugs. Stage 3, anytime, you want to take a new medication or there's something new over the counter, just run it by your doctor before you take it. Make sure it's okay for your kidneys. Be nice to your kidneys. The one renal guy I used to work with. Again, cardiovascular management, depression evaluation, really at any time through this process. But, we're looking at now you're going to a nephrologist, the kidney function is getting worse. Things are, more significant lifestyle changes need to be done at this point. And a depression evaluation or, even getting into some type of support group may be a good idea. This is the point too where they might start talking about dialysis. One little thing about dialysis, because I kind of in this lecture want to focus more on the 1, 2, and 3s than but if you are at stage 4 and you go to a nephrologist, he may start to talk to you about dialysis, not meaning that you need to have dialysis immediately. But the the fistula they need to put in for dialysis takes, I believe, in the neighborhood of 6 months to become healed enough to function. So most of the kidney specialists I know want to kind of get a jump start on it. If they start to see, this trending down. So, you may be talking about it a lot sooner than it's going to happen for that reason. At this point, low protein generally is advised because the kidneys are having trouble. They're probably at this point, stage 4 or 5, spilling a fair amount of protein because the kidneys are having trouble reabsorbing the proteins. So the more protein we put in the system, the harder it's going to be, knowing that you still need some protein, and a low potassium diet because the potassiums are electrolytes that kind of go a little crazy. There may be also issues with other electrolytes too. So here's some resources that take care of your kidneys is a good one. That measure your blood pressure. I put that in just to talk about if you're taking your blood pressures at home, which they recommend if you have high blood pressure. You should be checking at home to see where you're going, and you don't need to check many times a day, but what I would recommend is to check at different times during the day. Your blood pressure may be something in the morning, and then you take your blood pressure medicine, and then it's something else in the afternoon. So maybe one day in the morning, one day in the afternoon, one day in the evening. Kidney basics from the National Kidney Foundation, and then how you estimate the glomerular filtration rate, which I won't do that, but the first 3 is good. So, and that's one of my favorite places. I also like to end with a little nature thing. There's Zion out west. And any questions?
Oh, wow.
Comments?
Well, Sue, thank you so much for such a thorough presentation. You are incredible. You can tell that you're a professor. A couple questions came through. Well, really comments at this point. Someone said, thank you for mentioning the herbal remedy cautions.
Uh-huh.
I think that's very
Yeah.
important. We've got a comment. Oh, I'm sorry. Go ahead.
Well, and many of them are good. You just need to be careful. They have the same, they can have the same risk without the same oversight. So like I said, what I do, I usually try to go with something made in the US and something certified. Because it may not even be what the herb is. It may be the filler that they put in there.
Oh, yeah. Oh, goodness.
Yeah,
It's definitely something to consider.
yeah,
If I'm jumping down a little bit, this is kind of along the same lines what we're talking about. We just started using one pharmacist for all of our medications. Made a
good
difference.
idea.
Yep. Now I'm
Yeah,
seeing.
they can watch the interactions because you can have two, the other thing to say, you could have two drugs that aren't really that kidney toxic on their own, but you put them all together and they could be. So that's a great idea to have, um, you know, if you can. Sometimes this stuff is insurance driven, but if you can, to have one pharmacist who can, one pharmacy that's kind of watching what's going on.
For sure. I'm just going to see. We've got a couple more comments here, but if you have any questions or ideas for classes or anything you want to pass along to Sue, we'll put that in the chat. And so I'm seeing checking blood pressure at different times of day is a great tip. Hmm.
Yeah, you don't want to be crazy. I speak from experience.
I
I
get
always tell
that.
my patients, any mistake you've made, I've done it. So I know from what I speak, but
Mm.
yeah, you say, okay, well, I'll do that, and then let me do this, and I'll half an hour later, I'm checking it again. Just, yeah, once a day, so you get a good feel of it, jot it down. Um, it's very challenging, um, well, for all of us, and as a provider, when you have someone come in and their blood pressure is pretty high, and always want to say it's white coat syndrome. Um, because I'm always concerned I'm missing an opportunity to get that blood pressure down, you know? Um, so taking it at home, documenting it, and bringing a log in is very helpful.
Mm, I could see that.
Yeah, because the longer that blood pressure stays elevated, the more damage you're doing your kidneys.
Hmm. Wow, that's all connected.
It is all connected.
And now I'm seeing, thank you so much. This was perfect. And thank you, Sue. Always love your classes.
Well, thank you.
Oh,
Anything
yeah.
you think of, just shoot a question, and really enjoyed it. Thank you. Um, and we'll see you, I think, in a few weeks for something else.
Yes, we will. I don't have that date with me, but I'll look it up. But everyone, you can check our website, and I hope you enjoy the rest of your day. I'll stop recording.